Hi, my name is Kelsey. Sarah and I did schizoaffective disorder. It fits both of our populations of interest as it has an onset age of 16 to 30 years old and can go throughout older age. It's commonly misunderstood and very slightly different in treatments from schizophrenia, and we both wanted to learn more about the differences between the two. History of schizoaffective disorder. The term schizoaffective was coined by Jacob Kassanen in 1933. Kassanen recognized that in some patients, the co-occurrence of symptoms would suggest both schizophrenia and mood disorders were present. The research diagnostic criteria made one of the first attempts to distinguish schizoaffective from psychotic mood disorders. Is this new? No, schizoaffective disorder is not a new diagnosis. It's commonly misunderstood as schizophrenia. The term schizoaffective disorder first appeared as a subtype of schizophrenia in the first edition of the DSM. Criteria for diagnosis. What does this diagnosis mean? It has been determined that a person has been suffering with these criteria and should have a diagnosis in order to start treatment and to start to understand what it is that has been causing the symptoms and to start to understand more about themselves and why they are feeling the way they are. Criteria to diagnose. The first criteria is an uninterrupted period of illness during which there is a major mood episode, major depressive or manic, concurrent with criterion A of schizophrenia. Criterion A of schizophrenia is two or more of the following: either delusions, hallucinations, disorganized speech, each present for a significant portion of time during a 1-month period. At least one of them must be 1, 2, or 3. So either delusions, hallucinations, or disorganized speech have to be present. Criteria 2, delusions or hallucinations for 2 or more weeks in the absence of a major mood episode, depressive or manic, during the lifetime duration of the illness. Criteria 3, symptoms that meet criteria for major mood episode are present for the majority of the total duration of the active and residual portions of the illness. Criteria 4, the disturbance is not attributable to the effects of substance use or another medical condition. I have been diagnosed as having schizoaffective disorder. How do I present differently than someone who has a similar but different diagnosis? It is important to know the difference between what you have been diagnosed with and something similar such as schizophrenia or schizophreniform disorder. Each must include the first criterion, A, which was previously stated. Schizophreniform disorder is distinguished by its difference in duration. This quote comes from the DSM-5. Another distinguishing feature of schizophreniform disorder is the lack of criterion requiring impaired social and occupational functioning. While such impairments may potentially be present, they are not necessary for a diagnosis of schizophreniform disorder. Case example. It's important to see schizoaffective disorder as being on a spectrum between schizophrenia and a major mood disorder such as bipolar or depression. Some of the symptoms of schizoaffective disorder include disorganized thinking, delusions, hallucinations, depressive symptoms, mania, or thinking that you're being controlled. So let's say Bill comes into the office. He complains of hallucinations, lack of energy, delusions, paranoia, and feeling depressed. Bill says that he has hallucinations for a few months, and then he has a major depression that coincides with his psychotic disorder at the same time. And then he says he recovers from the depression, but for a few months after that, he still has psychotic behavior. This could be characterized as schizoaffective disorder because the mood symptoms have resolved, and for a couple months after, he's still having those psychotic symptoms.
Let's take a look at a short clip to better our understanding about schizoaffective disorder.
Let's say you've got this circle for major mood disorders like depression, mania, or bipolar disorder. And then this circle represents schizophrenia and symptoms of psychosis like hallucinations and delusions. If we combine these two sets, this middle chunk is what we call schizoaffective disorder, which, as we can see, has both a major mood disorder and also symptoms of schizophrenia. Now, just like schizophrenia and mood disorders, though, there have yet to be any imaging or lab tests that we've developed to definitely tell us that, hey, this person has schizophrenia, or hey, this person has severe depression, or this person has both, meaning that they would have schizoaffective disorder. That being the case, we have to look for symptoms of both schizophrenia and a mood disorder to come up with a diagnosis of schizoaffective disorder.
People with schizoaffective disorder or other mental health concerns are said to show a variety of cognitive impairments. This evidence-based intervention, called cognitive remediation therapy or CRT, is very useful for being effective in treating schizoaffective disorder. The definition of cognitive remediation therapy is it's a collection of techniques to improve cognitive functioning and social skills for clients with a variety of disorders that affect cognition. This therapy combines repetitive learning and strategic learning methods. Some areas of cognition that can be improved using CRT include planning, memory, executive functioning, language skills, problem solving, distraction, and a lot more. The executive functioning means that it's skills related to everyday work, learning, and managing life on a daily basis. Some processes of this therapy include group sessions, individual sessions, computerized activities, and worksheet activities. The computer activities are probably the most common, and also they're more efficient and standardized. The diagnoses that would benefit from CRT besides schizoaffective disorder include schizophrenia, bipolar disorder, anorexia, and much more. So, where's the evidence that CRT treats or improves the negative symptoms of schizoaffective disorder? I found an article by Lopez Fernandez et al., in which they conducted a meta-analysis review of studies completed using cognitive remediation interventions to determine the effectiveness of treating individuals with schizoaffective disorder. The sample size was with 4 studies that were chosen that met the criteria of people with schizoaffective disorder. 2 studies were completed in the US, 1 study was completed in Spain, and 1 was completed in Germany. A total of 73 out of 216 individuals were identified to have schizoaffective disorder from these studies. The results of the findings showed positive outcomes, including the severity of symptoms did not matter. One study found an association between higher levels of negative symptoms and greater benefits, and between higher levels of positive symptoms and greater improvements in functionality capacity. So pretty much wherever you are on the spectrum, you still were shown improvements in effectiveness. So another area that it improves is symptoms and functionality. It also could work with younger and older adults. It improves quality of life, improves cognition, and social skills. Implications for intervention. Gallatley and Rigby, 2013, found that using cognitive remediation therapy or CRT with a holistic approach may benefit individuals with the severe mental health concerns, such as schizoaffective disorder. The authors concluded that by combining vocational supports and programs, along with looking at a psychosocial perspective, can greatly increase the effectiveness of this therapy. The principle of taking a holistic approach, I believe, aligns with our social work perspective because often we look at all areas of functioning with somebody's life. Some positive and negatives about living with schizoaffective disorder include the positives include once someone is diagnosed, then they can use therapy and other methods to improve their quality of life and or decrease negative symptoms associated with schizoaffective disorder. Some negatives include stigmatizing labels, which oftentimes prevent people, like once they're diagnosed, it prevents people from wanting to come back and getting the treatment or help that they need. There's another negative aspect is self-stigma. An example of this is I'm never going to be normal. And then also public stigma, which is where the general public has a stereotype that most or all people with severe mental health concerns such as schizoaffective disorder are dangerous. Here's our reference list. Thank you so much for listening to our presentation. If you guys have any questions, please feel free to reach out to us, or you can post on the discussion board. Thank you guys again.